Okay.
Um,
Okay, great.
Feel free to take that share screen and take over, and you've got our rapt attention for the next 60 minutes or less.
Okay, great. Let's see. All right, can people see the screen now?
Yes, we can.
Okay, great. So yeah, thank you, Chris, so you're seeing the full screen, correct?
Yes, wildfire smoke and health effects
Okay.
research.
Okay. Yeah, so thank you for inviting me. This is like an interesting opportunity. You know, I usually would be talking to public health professionals and epidemiologists, and now I get to talk to experts in really a different discipline. So I'm interested to hear what your thoughts and comments are, and what your experience has been with wildfires, in your respective Western states also. So my talk is going to focus on what we know about health effects from wildfire smoke. It's a little bit California centric. I am a California Department of Public Health employee, so just apologize in advance for that. Let's see. So just a disclaimer that my presentation doesn't represent official policy of the California Department of Public Health. So as I said, I'm going to be talking about the impacts of wildfire smoke. I'll give an overview of what's known based on current studies, kind of what we can glean from air pollution studies and some of the knowledge gaps. And then I'll talk about some of the research that we've been conducting at the California Department of Public Health, which includes some work on prescribed fire. So as Chris alluded to, the last few years of catastrophic wildfires have really opened our eyes to the serious impacts of both the fire and smoke. Millions of persons have been exposed to wildfire smoke. In the past, wildfire smoke might have just been an issue for people living near, in the local vicinity of fires, but this is much more widespread at this point. The image shows California, Washington, and Oregon in 2020 as,
I have not seen the slides advance.
Oh, okay.
Over in that bottom left-hand corner, there you go. Great.
Okay. Okay. Thank you.
Good.
Good to catch that soon.
Thank you.
So, yeah, there were over 100 wildfires burning in September 2020, and that ended up blanketing most of the West Coast in smoke. So this graph shows the person-day exposure to wildfire smoke in California. Obviously, there's a dramatically increasing number of persons exposed to smoke over this time period. So person-day smoke is the number of days times the population count that was exposed. So another aspect that makes this more public health relevant is that more and more of us are living near forested areas in the wildland-urban interface. And that number is increasing by 1 million persons every 3 years. And over 38% of US housing is now located near wildland. So the global mortality has been estimated also. So this is not just an issue for us in the Western US or California, but researchers have estimated that over 300,000 persons, 300,000 deaths may be attributable to wildfire smoke globally annually. And clearly smoke can travel long distances. This illustrates smoke from California wildfires spreading as far east as New York City and the East Coast. So the smoke from wildfires are now contributing to our background levels of air pollution. And we've had decades of progress in air pollution improvements from the Clean Air Act and other legislation. And wildfire smoke is threatening threatening that progress. And in some areas, wildfire smoke now contributes up to 50% in some of the Western US regions to background air pollution. Another metric to look at is acres burned. So this shows the increase from the 1960s, and even it only even goes to 2015, but you can see the dramatic increase in acreage burned. So this all points to a changing fire regime, and the wildfire season has increased by 80 days in parts of the U.S. We're seeing increased temperatures, earlier snow melt. This photo here shows our former Governor Jerry Brown on the annual effort to measure the snowpack depth. And of course, in that drought year, there was no snowpack whatsoever. And even in early 2021, weather scientists were looking at the fuel moisture content of soil and detecting that it was extremely dry. So they were already predicting fires for the coming season. And climate projections have looked at what the increase will be in wildfires over the few coming decades, and it's estimated that the number of fire-related particulate matter deaths would be doubling by the year 2100. So this lists known or suspected health effects to be associated with wildfire smoke. Certainly, a lot of us have experienced, eye, throat irritation, but there can also be, shortness of breath. Asthma is clearly identified in many wildfire smoke studies to be increased and very sensitive to wildfire smoke. And then there's some more serious outcomes potentially also, mortality. Interestingly, the cardiovascular outcomes in epidemiologic studies haven't always been, clearly identified. And we'll talk about that a little bit more. And there have been some studies looking at adverse birth outcomes, even related to wildfire smoke. So what happens when you inhale smoke? So fine particles and coarse particles from the ash are respiratory irritants. The smaller the particle, the more deeply they'll penetrate into the lungs. The smallest particles can cross into the bloodstream, and thereby enabling those particles to have systemic effects. So a lot of what we know, or the base of knowledge, is from a wide literature studying urban air pollution, and all of the effects listed here have been clearly associated with urban air pollution, different types of mortality and morbidity. And in 2020, the American Heart Association declared that there's unequivocal evidence for particulate matter 2.5 to have a causal role in cardiovascular disease. So wildfire smoke is one component, obviously, of air pollution sources. There's mobile, stationary, and urban sources as well. And there's some differences between the type of particles that are in each of these sources. And and even within wildfires themselves, it'll depend on what type of fuel is being burned. And it's also important to realize that wildfire smoke can react with other components that are in the atmosphere and possibly creating secondary compounds. Ozone can be formed even at distances quite far from the original fire. And the smoke particles can also provide a surface that other components can latch onto, and that can facilitate transport of other toxic compounds or even infectious materials to other locations. So it's important to realize that that vulnerability matters. It's not just the dose or the concentration of the exposure or the duration, but the individual susceptibility of the population that's getting exposed. And then issues like pre-existing health conditions and age are important. But at high enough concentrations, anyone could be susceptible to health effects. So the list here is, identified known vulnerable populations. Obviously, people with pre-existing conditions and others who are considered vulnerable generally. And then we put outdoor workers in the list as well because of their greater exposure. And a number of studies have shown that persons who have a lower socioeconomic status may be at greater risk, and that's for a multiple, set of causes. They may have some of the other pre-existing conditions, but less access to healthcare, less ability to protect themselves during times of smoke. Any number of factors go into that. Looking at persons with cardiovascular conditions, which could include high blood pressure or coronary artery disease, other conditions, they may experience fatigue, shortness of breath, other symptoms, but also serious effects like heart attack or stroke. And to try to understand what the mechanisms might be for how cardiovascular effects happen. So the PM 2.5, will enter the lungs. It can impact the autonomic nervous system, creating an increased heart rate, cardiac dysrhythmia. And then there's some other mechanisms through a systemic inflammation or direct bloodstream effects that can lead to blood clot formation. So these various mechanisms could have clinical outcomes of heart failure, cardiac arrest, or stroke. So there's a number of mechanisms or pathways that these events could happen, could be caused. And there have not been that many studies of pregnant women, but several studies have shown an increased risk of low birth weight in women who are exposed during pregnancy or preterm birth. And during pregnancy, it is a vulnerable time. There are a lot of increases physiologically in pregnant women that may make them more vulnerable to environmental exposures such as wildfire smoke. And this is maybe an unusual vulnerable population, but a study did look at hemodialysis patients and saw an increase in all-cause mortality linked to wildfire smoke. There was a 4% increase in mortality for the same day of exposure. And then cumulatively over 30 days, there was a 7% increase. So not all effects would happen necessarily on the same day. And, ozone has been looked at also just a little bit because it is a component of wildfire smoke. One study in Northern California did not find an effect. They didn't with respiratory hospitalization, but the ozone levels were not particularly high. They were similar to time periods without fire. However, a Canadian wildfire study identified that wildfire smoke had been transported downwind and led to ozone formation as far south as Maryland. So, along the lines of vulnerability, Australia has a number of wildfires and they've done a lot of the good research. In this study, they're looking here at chronic obstructive pulmonary disease and hospital admissions for that condition. And they looked at an indigenous population and also compared it to a non-indigenous, like the general population. So the general population saw a 20% increase in hospital admissions for COPD in relation to wildfire smoke. But when they looked separately at the indigenous population, and that group can be expected to be lower socioeconomic status and also have underlying health conditions, there was a much higher increase, 100% increase in the COPD hospitalizations. And then looking at a different outcome, ischemic heart disease, once again, we see elevations in the indigenous population. And lag 0 is the day of exposure, lag 1 is the next day, lag 2, 2 days after. So we're seeing, an effect that's continuing for several days. But if they had only looked at the general population, they wouldn't have detected these effects that seem to be occurring in the more vulnerable group. And in fact, some of these, if you look at just the group with the indigenous excluded, it looks like there were fewer hospital admissions for ischemic heart disease during wildfire exposures. So many questions remain, like what is the significance of short-term spikes in particulate matter compared to like longer, sustained levels of exposures? And are there long-lasting effects? So as you can imagine, it's a lot harder to try to study some long-term effects just from an epidemiologic standpoint of how do we find out what happened much later. And I noticed that at least one person is from Montana, so you may know about this study, but they used the 2017 very large wildfire event, which lasted a long time period with very high exposure levels, sort of as a natural experiment to study this question. So they did some mobile health screenings shortly after the fire event, and they followed up participants and found that there was decreased lung function even 1 year after the fires, and then there were lingering effects 2 years later as well. And then also the UC Davis primate lab, this ended up being another natural experiment where monkeys were exposed during a wildfire in the 2008 summer. So these were monkeys exposed as infants, and they decided to follow them and compare them with another cohort of monkeys. And at 3 years, they found that there were compromised lung function and other effects that were apparent. So the question of the short-term spikes versus lower levels is relevant, and the next couple of slides show the air quality, or the AQI, after the start of the Northern California wildfires in October 2017. And those fires started on a Sunday night at 10 at night, and this is what the smoke picture looked like at 7 in the morning the next day, with the very high levels of smoke all around the Bay Area. But then by 9 o'clock, the pattern had changed dramatically, and then 11 o'clock, and then 1 o'clock. So we can see that it's a moving target of where exposures might be and how high they might be. So now I'm going to transition to talking about some of the research that we've conducted. There are a couple of studies. The first one, we studied a population of Medi-Cal beneficiaries. So they would be expected to be, somewhat of a more vulnerable population. Also, more weighted towards young children as enrolled. And then we focused in on cardiovascular outcomes as well in another study. And then very specifically on used a registry that looked at cardiac arrests that happened outside of a hospital. And then I'll also talk about our current research on prescribed fire. So in our study of the Medi-Cal population, this was based on a very large wildfire in San Diego in 2007. And, in this fire, there were over 500,000 persons evacuated. There were multiple school and road closures. So it was a very significant fire. So what we found, not unexpectedly, that we saw a large increase in asthma, hospital emergency department visits. That's the red line with the dot there. And the green is hospital admissions, and the blue is outpatient visits. So all of those are elevated, but most impacted are the people going to the emergency department. And we divided this into 3 time periods. The 1 to 5 is a peak exposure time for the wildfires, like those first 5 days of where there was a lot of smoke and fires. In days 6 through 10, fires were still burning, but they were diminishing. And then by day 11 to 15, those fires were pretty much gone, those effects. We looked at upper respiratory infections as well and saw elevations for the emergency department visits, primarily in the first time period. And then we looked at lower respiratory infections, bronchitis. And the lower respiratory infections didn't just pop up in those first window of time during the peak wildfire time, but persisted over a longer period. And then similarly with pneumonia. And I would suspect that that's because pneumonia as an infectious process may have taken a little bit longer to develop. And that's why we're still seeing, impacts in that third window of time. And we also broke the population down by age groups. And the very young children, age 0 to 4, were really the ones that had the highest, were showing the highest effects of the wildfire smoke. The older children were looked more like the adults with not quite as dramatic of an impact. And then when we took it down to even a younger age of infants and 1-year-olds, that was the group that really showed the most impact for emergency department visits. The far left bar there is for asthma, and that was the most impacted. And then we also wanted to put this in the context of the AQI, as that's the measure that a lot of people are familiar with. We looked at the effect on the same day, a 1-day lag, and a 2-day lag. And the highlighted boxes are the ones that are statistically significant. So if you're looking at the same day, we can see that when you get to a hazardous level, that we had a statistically significant association with wildfire smoke. But even below that concentration, we are seeing elevated odds ratios for emergency department visits for respiratory outcomes. And then we're seeing them reach statistical significance in 1 day and 2 days following the highest exposure. And then this study is focusing more specifically on the cardiovascular effects. And here we were looking at the wildfire season as we defined it from May through September in 2015. And there were a number of fires in the Central Valley during that time and Northern California. The map shows the number of smoky days. And the darkest red shows 60 or more smoky days. So you can see that Northern California and part of the Central Valley was greatly affected during that time period. And the results here, and I'm focusing on adults age 65 and older because that's the population where we really saw the most impact. Our summary measure here is the all-cause cardiovascular, and we're looking at yellow, orange, and red, so that's light, medium, and dense levels of smoke. And so you can see, the denser the smoke, the stronger the relative risk. And then we're looking at over the same day exposure up to 4 days afterwards. And we can see that those effects kind of diminish over those days, but they still are persisting somewhat even on day 4. And then looking at our results from the study of out-of-hospital cardiac arrest. So cardiac arrest, these events are captured in a registry, and there were 14 California counties that were participating in this surveillance system at the time. And these are arrests that happen not in a hospital, and they're attended by emergency medical services. So this is a very fatal, highly fatal event. 90% people do not survive, and only 30% actually are hospitalized. It's a little interesting because many people who have a cardiac arrest were not aware they had an underlying cardiovascular condition, and this becomes their sentinel event to be aware of it. So while we do tell people if you have a cardiovascular disease, then you should be aware of smoke and you should take precautions. But it's interestingly to realize that many people are not aware and wouldn't necessarily take action or preventative or see themselves in that vulnerable category. So what we found generally here is that under heavy smoke conditions, pretty much everyone has, we're seeing this effect of increased out-of-hospital cardiac arrests during heavy smoke. And then we also broke it down into lower socioeconomic status group and a higher. And when we looked at the lower group, even under a medium concentration of smoke, we were still seeing increased odds for cardiac arrest. And then in comparison, looking at the higher socioeconomic status, we weren't seeing that effect at all. And again, we're kind of seeing even an absence of an effect. So to look ahead, the big questions we're all grappling with is how do we address this threat from increasing wildfires? And thinking about the response, interventions become important. Portable air cleaning devices are important. Studies have shown that they're really fairly effective. They can reduce between 50 and up to nearly 80% in indoor particulate matter levels. These portable air cleaners can. And California Air Resources Board has some good information on their website about selecting an air cleaner and using them. And then, of course, prescribed fire is a really important tool. And the state of California has entered into an agreement with the federal agencies to treat 1 million acres per year. This is vegetation treatment, so it's not only prescribed fire, but includes prescribed fire, with California treating 500,000 and federal agencies treating another 500,000 by 2025. So this This is a huge scale up. You know, in the past, maybe we were in the tens of thousands, and it's very ambitious to try to go to 500,000. So there's a lot of work going on around this. So not that much has been done to like systematically look at what the impacts are from prescribed fire. You know, they're designed to be low impact. They're designed to stay within a level that would be safe for nearby populations. This particular study, the blue line shows the concentration of particulate matter from a prescribed fire, and then they overlaid that with the particulate matter concentrations from a significant wildfire. A couple other studies, one other showed that there was very little effect on local air quality, and it was in the Sierra Nevada area, and the readings were pretty similar to non-fire times. Another study in Australia, you know, in an area that's impacted by frequent prescribed fire burns, they found that the smoke exposure was typically really short in duration, but there were some very high short-term hourly peak exposures, like as much as 225 micrograms per meter cubed. And then there's another study that looked at children in Fresno and found that when they were exposed to wildfire, they had more symptoms than when exposed to prescribed fire. And another study in Georgia did find increased visits for asthma to the emergency department. Of course, the prescribed fire regimen in the Southeast is a lot different from what we experience in Western states. But nevertheless, since there's not that many studies right now on prescribed fire, I thought it was worthwhile to look at that. So we clearly accept that there's a need for prescribed fire, but we also recognize there's a need to protect populations and human health. So the question is, how do we manage this and handle this effectively? So I'm going to talk a little bit about our study of looking at the public health impact of prescribed fire. I have a number of collaborators, Sonoma Technology, who's doing the exposure modeling, US EPA, US Forest Service, and Michigan Technological University. And this is a study funded by CAL FIRE. So like I said, we're investigating the potential public health impact of smoke. And there are three basic components. There's the smoke and exposure modeling, and then we'll do a health analysis. And a smaller but very important part is the community engagement aspect. So for smoke and exposure modeling, we're looking at what's the difference between in PM 2.5 concentrations, and we're looking at several scenarios. We're looking at a baseline of prescribed fire burning, and then the target that's driven by the goals for treatment that with CAL FIRE and the federal. And then we want to put that in the context of how does this compare with wildfires. So baseline prescribed fire scenario, we've gathered up, you know, all the information that basically exists on prescribed fire emissions or prescribed fires, you know, historically, and then using a lot of models to estimate fuel and then modeling the smoke emissions. And the target prescribed fire scenario, you know, like I mentioned, we're basing it on the 500,000 goal of treating that number of acres. And we're focusing on areas that CAL FIRE has identified as priority lands for community. So this is a combination of areas that are known to be high fire hazard risk and also are populated, because a lot of California is forested and not populated. Another component of the study is to look at greenhouse gas emissions and quantify emissions of CO2 and methane with the different scenarios and try to estimate the potential net benefits. Wildfires are now contributing substantial amounts of carbon dioxide to the atmosphere. So our health analysis, we're going to look at these several scenarios and focus on and use data on hospitalizations and emergency department visits, and then calculate the health burden from the different scenarios as well. And we did several things for community engagement. The first thing we did was conduct listening sessions in El Dorado and Nevada County. And these are areas that are in the wildland-urban interface. And we wanted to find out directly from residents, like what is their experience with smoke and symptoms and life impacts from wildfires and prescribed fire. What do they know already about prescribed fire? What is their health protective behavior for smoke? And then really importantly, what are their ideas for how community resilience and preparedness can be improved? So these are some of the feedback that we got during the listening sessions. Definitely people were very supportive of prescribed fire, but at the same time, they had concerns. And most people reported experiencing some health symptoms from smoke. Most did not differentiate between wildfire and prescribed fire smoke. But this quote from the second quote here, when the person who says that they're asthmatic, and they say when there's forest fires or prescribed fire, they have to use their inhaler. But at the same time, that person recognized that it's important for the safety of many, but it does affect the person's health. So I think that's kind of how people feel like, yes, we need to do this, and yes, there's some issues that need to be addressed. And part of what we valued about this part of the study was that we can capture some information that we wouldn't be able to just looking at counts of people who went to the hospital or the emergency department. People talked about quality of life types of things and mental health issues. You're feeling depressed if you can't go outside because it's too smoky for days on end. And people in these areas who are familiar with wildfires, they've become like sensitized to this. And if they smell smoke, they urgently need to know, like, is this prescribed fire or is this wildfire? Do I need to take action? Do I need to be evacuating? And then just people trying to grapple with how do they protect themselves? They don't necessarily have a good air filtration system, and so they're struggling sometimes with how to do that effectively. But nevertheless, people came up with a lot of positive ideas. There was a lot of support for local activities that would provide education. They felt like the more education about prescribed fire, the more people would accept it and support it. One idea was, like a community festival type of thing where the fire department in partnership with community would have a fun educational event, maybe even do like a demonstration prescribed fire and make it fun, make it feel like a festival. And then the other community engagement activity that we did was in Mariposa County. This is a very, very rural, small, fairly low-income county. The health officer maintains a program called SAFE, which is a self-identified list of medically vulnerable persons. So these are people who may need assistance during an emergency, not necessarily just limited to wildfires. And so we surveyed them. These are older people, typically. They do not use the internet, so we mailed things to them. And we just recently finished the data collection for that. So a number of questions, persist, like, do these health conditions persist after fires? What are the most effective interventions and treatment, and can we increase the forecasting ability to help people reduce exposures? And probably most importantly, how do we build resilience, to a warming climate where we'll be experiencing increasing wildfires? So I just wanted to acknowledge my colleagues for these different studies from various organizations. And thank you so much. So I'll have any questions, or I'd be interested in hearing your thoughts.
Thank you, Sumi. Yes, let's open this up for questions here. And I'll go ahead and start with a few things that I think might be of interest to this group. Is where do you see opportunities for more public education about wildfire smoke? And also just the education of showing how the difference between wildfire and prescribed fire, and that's those impacts on wildfire, on smoke, that I think we could partner with some of our colleagues to talk about.
So, well, first of all, I don't have the communications background, but we did do these listening sessions and also, the Mariposa survey. And I think what we got from the listening sessions was people really felt like communication at the local level was the most effective. Like they needed to have communication with their neighbors. That's where a lot of trust will be. They also suggested that maybe some existing structures could be used, like some of the fire safe communities, communications that are set up for emergency response. If we incorporated smoke education and education about prescribed fire, that could be an efficient way of reaching people. But people really thought all of the above, like let's do a broad media campaign and do things at the local level and just try to develop resources for all of that.
And do you have some resources we could turn to that some good information that already exists? So I know it's not your area, but if you just suggest some, we can find them.
Oh, no. Well, okay. Interestingly, I think that's on everyone's mind. And California just passed some legislation, AB 619, that's going to like focus in that area. What the legislation does is ask the health department to create this kind of information. We have some, but it really needs to be pulled together in a focused way. And there'll be some more staff hired, and there'll be collaborations with different agencies, air pollution control agencies, nonprofits, medical community, and to develop these templates that then can be picked up by counties and other jurisdictions to use locally. And then each county is going to be required to come up with a plan, and they can adopt these materials. So that you're recognizing that that's a clear need, and we need to have this more more focused attention devoted to that. Some other states that are really pretty advanced in this are Oregon and Washington as well.
Yes. Thank you. We are a meeting, so we can go ahead and unmute. Peter, I'm going to get Carrie's message here first. She's asking, when do you anticipate the results of the study PHIRE, fire?
Fire. So different parts of it will come out at different times. We actually just released a report from the listening sessions, and I can send you information on that. The full report, we're going actually through an ADA process to make it like completely accessible. So we hope to have that posted, but I can send that document to you, Chris, if you want to distribute it, or okay. And we're preparing some manuscripts also. So one is, some are closer to being ready than others, but they should be coming out, and I would love to share it with the group.
Thank you. All right, Peter, go ahead.
So, there's always a difference between the theoretical and the practical reality. And there's a couple of components in this study that concern me a little bit. And that's based out of the practical reality is that typically fire season occurs during the hottest and driest months. So where I am located in Montana, that would be starting in July, August through September. And it's become a reality here that during those months, every other year, we're going to be breathing a lot of smoke. Okay, so prescribed burning is a tool to try and reduce fuel loading and protect certain areas, particularly the wildland-urban interface. So the reality is now, instead of only having 2 months of smoke, we now have smoke in the spring, May, June, July, or well, May and June from prescribed burning. Then we have the 3 months of smoke from wildfires. And then we have smoke in September and October, November from further prescribed burning. So the real two questions here then. So what are the health impacts of now, rather than breathing 3 months of smoke, we're breathing 7 months of smoke? And secondly, more on a logistical scale, at what point does the prescribed burning reach the capacity where it is having an impact on wildfire smoke? So we're seeing less wildfire smoke because we're doing this prescribed burning. So what are the models there? Because typically on a prescribed burn, you need to burn a site twice in order to get the fuel reduction you want. The first one kills a lot of vegetation. The second one consumes a lot of the woody vegetation or the woody debris that you've created with the first fire.
Right. No, I think those are the key questions that everyone wants to know, right?
Right.
But I again, I'm not the firefighter either, but I think, we would hope that the prescribed fire smoke is minimal compared to what you're getting during those wildfire smoke seasons. And I don't know, is that not your experience?
No, not at all. I mean, the spring, we get nice weather. As soon as the weather turns nice, you're choking on smoke, because the problem with the prescribed burn, it's done when your fuel moistures are higher, so that you don't get extreme fire behavior. Well, with higher fuel moistures, you get more incomplete combustion. So per volume burn, prescribed burning tends to produce more smoke than when those fuels are very dry. And so, your wildfires produce a lot more because they're consuming a lot more vegetation, a lot more material.
Yeah. Yeah.
And Peter,
No,
I think, go ahead. I'm sorry to interrupt, but whether you're in a valley, you get inversion issues by burning at different times also.
Yeah, which is a real problem in Western Montana. But basically, our high schools are having to shut down spring athletic events like track meets because of prescribed burning smoke.
Wow. That's I'm really sorry to hear that. Believe me, I don't know the answer to this. People say that yes, prescribed fires are supposed to be, kept at a lower level. And I think in California, they've been fairly successful at that. But I hear what you're saying. It sounds like you're just experiencing that in an ongoing manner.
Well, and so the real question is, we're going to have to endure more smoke for 10 years so that we have a century of less smoke. I mean, the problem is that we're only burning the wildland urban interface, and our wildfires are in the higher elevation forested areas that are outside the wildland urban interface. So what we're really facing is the cure is creating a worse problem than the initial problem.
Well, I think we're in California. I think we're burning not just in the wildland urban interface, but other areas too. But I don't know specifically. So it's your impression that we're creating a worse problem by doing the prescribed fire?
Well, at least in the short term. But again, I'd like to see an analysis done of, okay, this is the number of years it will require for us to get to actually have a reduction in wildfire smoke from prescribed burning. I haven't seen that number or that statistic or that kind of a study done anywhere.
And I'd like to open that up to some of our colleagues, because I know this gets out of Sumi's realm, but we've got a lot of expertise right here. Peter, Max, you got anything to add to that?
Well, I'm not sure that I can respond definitively to Peter's point. I think it's a good one, and probably local experiences or regional experiences vary. But I guess what I would like to see is some sort of assessment. We focus a lot on prescribed fire, and I personally believe it is a critical tool for improving forest resiliency and reducing long-term smoke impacts. I think that's my personal view. But I also think that we need to step back and think about all of the tools in the tool chest, including mechanical fuels reduction, thinning, biomass, things that are perhaps getting less emphasis now. And I think there's research to say that in terms of fire severity, probably your best treatment is a thin followed by an underburn. But when we look at smoke production and takes net aggregate smoke production as the metric, I think we really need to be looking at what are the what is the best combination of treatments that probably includes prescribed fires, probably, maybe it includes some managed wildfire, maybe not. Maybe, you know, we have fire suppression that we can deploy, and we have mechanical fuels reduction. What is the optimal combination of those treatments to reduce net aggregate smoke production? I don't think we know. And I find it
Right, we don't know.
concerning that, you know, at least in the forest restoration community, it feels like we focus a lot on wildfire severity and aren't addressing some of these larger questions around long-term smoke production.
Yeah. I think California Air Resources Board is trying to look at comparing and some of these different measures also. And we're just focused on, you know, the health impacts of prescribed fire. But, you know, these are the big questions. And I do think that prescribed fire is going to be important in curtailing the ability of when a wildfire starts to become a mega fire. But whether it can like really reduce, you know, it can be the panacea to reduce all of the smoke, probably. And then it becomes important for people to have to take some, you know, health protective behaviors on an individual level, which is not ideal, obviously, but maybe necessary at times. But yeah, thanks for that perspective that we need to look at more tools, you know.
I had a question for Sumi. Toward the end of your presentation, you mentioned that the elderly don't use online resources or don't access the internet. And I was curious, you know, is that a guess, or is that based off of some sort of survey research? Because that's something that concerns me about our movement to online delivery as the only source of the way that we convey information. And one of the things we do is we ask people how you'd like to learn and how was this experience and all that stuff. But those are people that have already tapped into your online programs, you know, and so I know that in Washington, we haven't done any sort of systematic inquiry as to how people would like to learn and you know, and who's missing out on something that they would have otherwise have attended face-to-face or preferred something sent in the mail.
Right. We ended up doing this on a paper survey because, I mean, obviously online would have been easier, but we were working with Mariposa County and they know that population. And we said, okay, so we would send them a little postcard and tell them to log on and enter their data in you know, and they're like, no, you can't do that. These people are not on the internet. And they know those individuals. It's a county of like 18,000 persons, and they know there are 250 people who are in that. So it was like a very unique way to reach people who are not going to, like you said, like you ask people who are already online, how do we best reach you? They're already online. And then, you know, related to this also was even in the listening session, and these were people who we did virtual listening sessions. So they were online and they were able to do that. We did a lot of hand holding, like every person, we walked them through how to get in. We did a sound check with everyone because some of them were like older and needed a little bit more assistance with that. But, you know, they said like, I mean, they're internet users, but they're like, in our area, internet can be lousy and it can go down and they can have power shut-offs. And so during a wildfire, you know, everyone's trying to log on to this local site and then that site goes down and they don't really know what's going on. And they're like, we need like a phone system backup to notify people. Or they're like, we could get a text message if the regular internet is down. So people are, this was in the context of how do we know about whether something is a prescribed fire or wildfire or what's going on in emergencies. But I think it is an issue, and I think there's a broader question of, it's like rural electrification, if you're familiar with that as a concept. Like people need access to internet in all these areas because it's become like a basic thing like water or electricity, I feel. That doesn't solve the question of do they know how to use it, but it would go a long way towards that, I think. So Yeah, I mean, I think it is a good question.
Can I throw in
I'm
another
interested if
question
other-
here, Chris?
Yeah, please.
Yeah.
Sumi, I just wanted to say thanks. I thought it was a great presentation and really appreciate the information. My question goes back to one of your first slides, which was kind of this worldwide estimate of mortality attributed to wildfire smoke. I think it was like 300,000 deaths. I just wanted a little more information about that. What was the time period? Was it sort of acute, short-term, impacts, or did it attempt to track, longer term effects? Just kind of a little more information about that estimate. Thanks.
I would have to look back at that study, but they weren't necessarily tracking any long-term estimates. It would have been based on what we know about particulate matter levels, and what we assume that certain increments of increase would be related to how much of an increase in mortality, and then multiplying that out by populations that are impacted at those levels. So yeah, I can follow up and give you some more information on that if you're interested. Yeah, I'd be interested if other people want to share their experience from wherever they're living. That would be interesting as well.
I guess I have a question, Sumi. First of all, I also learned a lot. It's great to see, that kind of data and study. Look forward to the paper and other products. One question I had was, is there and maybe other folks know, is there an extension equivalent for public health that can link to? So one of the things that intrigued me, and I've heard this before, is these portable air filters, these HEPA air filters, as a kind of a public health resource that would be distributed by, local governments or state agencies that might end up being exposed to planned fires. If we know that there's going to be particulates in the air, Denver is an air quality horrible place to hang out, and so there's more emphasis in how can we work together as public organizations to educate people on when air quality might be compromised, and then B, how to link them with resources like these portable filters, where they can either check them out, they could be distributed to healthcare facilities or elder care facilities and those kinds of things. I'm just sort of wondering if there's a network like that, because this is not an issue that's going to go away. I'm just curious what you're hearing on that kind of extension and engagement side.
Yeah, we don't really have a public health extension, but you're really right. There's going to be a need for portable air filters. Right now, there's a small pilot program in California where some communities are able to get like a cache of these and then distribute. I've looked with Sarah Cofield in Montana. She's like familiar with all these things and has gotten a grant to get some resources. But we can't just all be individually going out and competing for grant money. That'd be like the beginning of the COVID crisis, where everyone was like fighting over vaccines. But I think that the legislation that I mentioned, AB 619, that also will be addressing how do we get some of these resources to populations, and how would we distribute them. It's not a small task. But you're right, with prescribed fire, at least we could have some advance notice about that too. And then there's just a general education for people who are able to afford them. Just trying to encourage people to make those purchases ahead of time, so they're not rushing out when there's a fire and there's no inventory.
Thank you.
So I have a more basic science question for you. We always talk about particulates, the 2.5 microns. Now, do the gases produced by fires, such as the aldehydes and formaldehydes and carbon monoxide, how are those accounted for? How are those measured with regard to health effects on people?
Well, the particulate matter is really like anything that's that size and below. So that can include all kinds of compounds, and I'm not sure the size of those things that you're mentioning, but if it's below 2.5, then it would be counted.
Above or below 2.5?
So the PM 2.5 means anything that's that size or smaller. So it includes very small things.
Okay.
So fine and ultrafine is all included there.
Okay, thank you for that clarification.
But I don't know the sizes of that. Yeah.
Okay. Well, Sumi, thank you so much. I think you had an audience very interested in what you had to share today. At least I know I stuck onto it really well. And we work a lot with trying to educate people about forestry and fire and the wildfires that we're seeing, that to know more about the impacts of smoke, and we're around it too. We breathe it. And yeah, so we hope to have a better relationship with our public health groups and our extension agents that deal with this area, and try to raise this awareness and have resources that we can share with our communities about being safe with wildfire. And so I really appreciate your time today.
All right. No, thank you for letting me comment. That was really interesting to hear your questions, and especially the questions around, what's the right balance with, or what's going to happen when we have prescribed fire for this many months, and when do we really get ahead of the curve? And I'll have that discussion with our team, because I think that's important to, we want to try to figure out the best way to grapple with those questions. So thank you so much.
You bet. Max has asked if there'll be a PDF of this presentation. If you'll share it with me, I can share your slides if that's okay with you. And I'd also ask if it's okay, I'll go ahead and cut this section of the webinar out and make this available as a resource online, or your presentation. Okay,
great. Well, thank you.
All right. Well, thank you. We'll let you go as you wish. We will bring our meeting to a close here. Our executive board will get back together in 60 minutes and kind of go over some of these ideas of what we've talked about, planning for our next face-to-face meeting with Doug, and making sure that we're up to date with all of our WCC requirements. So any last words before we take off here?
Thank you so much. Really appreciate the opportunity.
Thank you all. Have a good afternoon.